Thank you for joining us. My name is Kim Sterling. I'm the Director of Marketing for NCCHC. I'm so glad you all found your way here. We received notice of this grant just in the last week, and that's why it wasn't in your brochure, but we are just delighted to thank Gilead Sciences for their support of this event and the ability to provide this information to so many of you all at one time. On the moderator instruction sheet, I just want to let you know that our speaker does not have any undisclosed commercial relationships. I'd like to ask that everybody turn off their cell phones and to make sure that you complete the session evaluation because you will get CE for this session. Before I introduce our speaker, I was asked yesterday to provide a little bit of information on a somewhat related topic, but not really, from the National Tuberculosis Controllers Association, who was here on our show floor. There has been a shortage of one of the major TB drugs, and production is back to full strength as of mid-October. There are some shortages that still remain. The National TB Controllers Association is creating a real-time reporting mechanism to show where the shortages are and any information on price increases. So if that is within your purview to be of interest to you, please check out the National TB Controllers Association website. So with that brief commercial, I'm really pleased to introduce our speaker today and our subject. The title is Hepatitis Education Programs in Prison, Implementing Peer Outreach and More in Washington State. Our speaker is Richard Pfeffer is the program coordinator for the Hepatitis Education Project in Seattle. He, on a daily basis, is teaching about viral hepatitis and HIV risk and bloodborne infectious classes in 12 Washington Department of Corrections facilities and in King County Jail. Regularly teaches courses. He directs the National Hepatitis Corrections Network, facilitates partnerships between agencies working on hepatitis C, has written newsletters, coordinates outreach events, and works with the board of directors and management to create and achieve their program goals. He is also an experienced ice hockey referee and has traveled extensively, oddly enough, in Latin America, where there's not very much ice hockey. He has a Bachelor's of Science in Criminal Justice and Sociology from Bradley University in Peoria, a Master's of Science in Sociology, Community Economic Development Programs from Illinois State University. And I'm pleased to say he is also a CCHP. So I hope you appreciate his presentation. I'm looking forward to learning quite a bit, and thank you for being here.
Okay, shorten this up just a little bit. Okay, thank you guys very much for having me. My name is Rich Pfeffer. It's been a while. I'm a bit nervous. It's been a while since I have spoken in front of this many people. I used to work for an agency in Chicago that worked with low-income high school students, and the last time I spoke in front of this many people, it was a room full of 400 rowdy urban high school students. So I am a hockey referee, so I can moderate well, but please just, I hope that you guys are friendlier than they are from time to time. No, they're great, actually. I am here to talk about hepatitis education programs in prisons and jails. We are going to be, I'm going to be talking about our program work from the Hepatitis Education Project, and I'm going to be focusing on implementation strategies. And I just want to take a quick sort of survey. How many people here are healthcare providers or in a prison or a jail? How many folks are health educators? How many of you work primarily in prisons? Jails? All right, I'm just curious kind of who my audience is because I'm not really sure. So we are going to talk about a lot of different stuff. I don't have anything to disclose at this time. There are three main educational objectives for this program. We're going to talk about the current state of hepatitis C in prisons and jails around the country. I'm also going to describe current sort of educational outreach models for offenders in U.S. prisons and jails, and I'm going to talk about 2 specific models that we have run, and when I say we, the nonprofit agency that I work for in Seattle, which I'll talk about as well, but 2 specific models that we have implemented in the prisons in Washington State. There is a non-educational objective for this lunch as well, which is that you guys get to eat lunch as well. So I hope you're enjoying it as much as Mario. Luigi looks a little upset. So anyway, enjoy your meal as well, all right? All right. So I work for a nonprofit. I work for a 501c3 agency, a nonprofit agency in Seattle. We are focused on raising awareness about hepatitis, but we provide a multitude of services around hepatitis C in the Pacific Northwest region, and we have a national presence as well. We provide education, advocacy, and patient support. We provide education primarily in prisons and jails, chemical dependency centers, transitional living. We provide professional development for nurses and doctors and anybody who works in healthcare and deals with hepatitis C patients who calls on us and asks. We also have a small youth outreach program as well that provides prevention information for young people in the greater Seattle area. Our executive director, maybe some of you know him, his name is Michael Ninberg. He is on trains, planes, and automobiles on a regular basis, doing local and regional and national level advocacy, trying to advocate for more resources for hepatitis, prevention, care, and treatment. We provide patient support in a lot of different ways. We are building a medical case management program specifically for hepatitis C. I think it's one of the first of its kind in the country. We're experiencing a huge amount of interest from clients and also a lot of interest from agencies around the country sort of asking what we're doing as well. So if any of you are interested in sort of what we do, I'm happy to talk to you all afterwards. We also provide linkage to care for people who we screen who test antibody positive for hepatitis C. We do provide hepatitis C free screening as well as free hepatitis A and B vaccines. We do that in our, we have a drop-in clinic every Tuesday for a few hours where people can drop in without an appointment, or we provide them in outreach settings as well. And we also provide a network of support groups that we're working to grow in the Seattle area as well for hepatitis C patients. So we provide a lot of different services, and I think that our prisons and jails education work is one of our strongest programs. It's one of our longest running programs. We've been working in Washington's Department of Corrections for over 10 years. I've been doing that work for about 2 years, and it's great, the work that we're able to do there. Oh, and by the way, we're only 5 people. So if anybody has any more money for us to hire somebody else, that would help out a lot. All right, so I'm not sure, sort of, depending on, I know a lot of you might be familiar with some of this information, but I do want to kind of give a brief overview on hepatitis C currently. Actually, I skipped a slide. There we go. So hepatitis C's prevalence nationally is about 2%. The CDC estimates that it's about 1.5, but we don't have very good surveillance, and I think most experts agree that the number is quite a bit higher than that. HCV mortality is also high. It's about 5 per 100,000, and that is rising. The majority of hepatitis C infection is among baby boomers, people born between 1945 and 1965. Hepatitis C is also a slow-acting virus, and many people are aging into advanced liver disease. So the, excuse me, the mortality is rising. Along with rising mortality, we have rising healthcare costs. So the current disease burden is about $8 billion in healthcare costs on an annual basis, and that number is rising as well. Hepatitis C is the leading cause of liver transplants in the United States and is a major cause of liver cancer. Treatment for hepatitis C is rapidly evolving. We have a lot of new drugs coming through the pipeline that we expect to make treatment shorter in duration with fewer side effects and a higher cure rate. And so we're experiencing somewhat of a revolution around hepatitis C treatment as we speak. So there's a lot of changes coming through the pipeline. People who are working with patients who are living with hepatitis C are going to have a lot, it's going to be more, there are going to be a lot more options for patients and providers, but it's going to be complicated to navigate through. Also, most new infections today for hepatitis C are among people who inject drugs, and we incarcerate people who inject drugs. So as a result of that, and among other risk factors, we have a big hepatitis C problem in our prisons and jails. There are about 2.3 million people in prisons and jails. I think a lot of you are familiar with those statistics, so I don't have to focus on that. And we have about 1 in 3 adults will have been incarcerated. About 30% of the total hepatitis C positive population will spend time in a prison or jail in a given year. Hepatitis C prevalence among prison inmates is at least 8 times higher than the general population. That's me being very conservative. The number is, the prevalence rates in prisons or jails is between 12 and 36%. And that's a huge window, right? But we don't have very good surveillance for hepatitis C, and we don't have universal opt-out screening, so we don't really know the exact number, but if it's 12 and the prevalence rate is 1.5 from the CDC, it's at least 8 times higher. So I expect that it's higher than that. There are guidelines, but no universal standards of care for screening, treatment, and care in prisons and jails. The Federal Bureau of Prisons does publish a set of guidelines that they recommend people use, but there is no universal standard, and we'll talk about that here in a few minutes as well. The other thing we have is a huge need for both offender and provider knowledge and resources, both financial resources, but also educational resources, and access to medications and resources there as well. All right, this is an example of some of the prevalence that we do see. In Washington State, we actually implemented universal opt-out screening in the 12 state prisons there, and so we do know how many inmates are coming into our system who test positive for Hep C antibodies. The number is about 18% for men, and the number is about 25% for women. So it's an average of about 19%. So 12 to 36%, and we're right in that window at 19%. There are some states that are higher. Rates in California and New Mexico have been shown to be over 40%, so that's an enormous number. Rates in Georgia have been shown to be more like 7.5%. I've seen it sort of theorized that that's a difference in terms of geographical distribution of rates of injection drug use, although we don't really know why those disparities exist. But this is just one example. All right, let's see. There we go. Now we got it. Okay, good. Okay, so yesterday, there was a speaker who spoke about the opportunity to address the HIV epidemic as a public health issue in our prisons and jails, and I couldn't agree more, and I couldn't agree more from the hepatitis C standpoint as well. This is a huge opportunity to make an impact on the public health epidemic that is hepatitis C. We have a large concentration of hepatitis C infection, especially and in particular chronic infection of Hep C, and this is an opportunity to make an impact and improve the health of our communities, as well as improve the health of the individual lives of the people who are living in prison. All right, so there are lots of different ways we can address this in prison. First off, we have a captive audience. We can test, and test again. Many of you are probably familiar with the new recommendations and guidelines that the CDC and the USPSTF, I always mess that up. I actually got that right today. That's good. But the screening recommendations for all baby boomers to get a one-time screening for hepatitis C. So again, baby boomers, people born between 1945 and 1965, the CDC recommends a one-time screening. When I talk about treatment as prevention, it's a little bit different than HIV. What I mean by treatment as prevention is 2 things. Treatment for hepatitis, by treating someone and curing their hepatitis C infection, because hepatitis C, by the way, is curable. By curing someone a hepatitis C while they're incarcerated, that reduces the risk for them transmitting that virus to others upon their release. And we do know that over 9 out of 10 prisoners will be released. So treatment as prevention in terms of preventing future new infections, but also in a sense that for people who go through treatment and do not get cured, which is that percentage is getting smaller and smaller as treatments get better and better. Treatment has been shown to slow down the progression of liver scarring and prolong life and decrease HCV-related mortality, even if a cure is not achieved or SVR is not achieved. All right. We have so we have better and more tolerable therapies, so shorter durations of treatment and more tolerable for whoever is on therapy are coming down the pipeline. We've got an explosion of telemedicine being used as a resource, both in our communities, but also it's been shown it works very well in a prison setting. In New Mexico, in Washington where we work, and in Utah and elsewhere, we've got they use telemedicine for treating patients in the criminal justice system. So with those resources becoming more and more available, we've got an opportunity to provide specialty care without actually bringing specialists into each site. We've got the ACA, which is going to make release planning a lot more complicated for some people, but it's going to give us an opportunity to get people access to Medicaid or health exchanges and provide options for people who might have been released into the community without any opportunity to have their hepatitis infection treated to be able to have access to the care that they need. So we're working really hard to be involved in that as well. It's an opportunity to educate both patients and providers. And we agree that there are many challenges. This is not easy. This is a complicated epidemic. There are lots of opinions out there. There are not a lot of resources. And as always, DOC budgets are stretched. So money is a big issue. We have changes in treatments. We have who to consider for eligibility. We have issues related to continuity of care and political aversion to treating patients in prison. So there's a lot of different challenges, but I think everyone could agree that this is a big opportunity. I think that right now we are missing a little bit. So I think I will tout again that this is just a big opportunity for us, and I'd like everyone to just consider that. How's your lunch going? It's okay? As much as you guys enjoy it as much as this? I hope so. He's not even halfway done. All right. All right. So what is being done around the country for both screening and treatment? We'll talk about screening and treatment first. And every system is different. Every state is different. Every private system is different. And there are I think the bottom line here is that screening and treatment practices vary considerably across the country. And without universal standards or sort of a guiding body, we see these high levels of variability. And with screening practices, I've seen, and I talk to people all over the country who are doing this work, and I've seen an enormous amount of variability. So when I talk about screening practices, I see lots of different practices. I've heard about prisons that screen people who are only symptomatic, which is scary with hepatitis C because by the time that most people with hepatitis C are symptomatic, their liver disease is very advanced. We've seen systems that screen only by request and with risk factors, or simply by request. We've seen risk-based screening, targeted risk-based screening, and also just reported risk-based screening. We've seen opt-out testing and universal opt-out testing, which is what we instituted in Washington a few years ago and has been very successful. Only about 1% of our inmates in Washington opt out of their hepatitis C test. There are two different sort of ideas in terms of screening on entry versus screening on release. Screening on entry provides the opportunity for the inmate to engage themselves in care while they're incarcerated. Screening on release provides the opportunity for the inmate to learn during the release process of their hepatitis C status and then be referred with a warm handoff to care or directly linked to care. And so those are two different models that you could consider, and they both have advantages and disadvantages. One of obviously the advantage of screening on entry is that you're able to engage people in care in some way, whether that means monitoring liver function and providing treatment as necessary, or whether it means providing treatment for all those who need it. Screening on entry also increases pressure to provide treatment, and treatment is very expensive. So as an alternative, there are systems out there that are screening on release, and also screening on release is also a potential opportunity for jails as well, where they don't necessarily have time to go through treatment with continuity of care. Screening on release provides an opportunity to let someone know what their status is, and to provide either a warm referral or a direct linkage to care with fresh messages in their brain. about sort of what's going on with their health. Now, the release process is a disadvantage to that is that the release process is complicated and overwhelming. And so adding another thing onto the plate of somebody who's being released is one drawback to screening on release. However, if there are some systems out there that feel that screening on entry provides a lot of pressure to provide a very expensive treatment and opens them up to legal risk, and so screening on release is one alternative to that system as well. Also, something to consider is whether or not screening antibody positive provides direct access to confirmatory testing. About 20% of people who screen antibody positive for hepatitis C will actually self-clear the virus. And so confirmatory testing is very important, otherwise we have a half diagnosis. And the reality is that confirmatory testing is very expensive. And so some systems provide access to confirmatory testing, some do not, or some do for some. And so those are some of the practices there. Systems are treating across the country, but they're treating a small percentage. And that's also true in the community. A lot of people with hepatitis C don't need treatment right away. And with all these new drugs coming through the pipeline, there are lots of people both on the inside and outside of prison walls who are being asked to delay treatment or advised to delay treatment. But I believe that the disparity between what sort of who's being treated in prisons and who's being treated in the community, there's a disparity there. But it's admittedly, treatment for Hep C is complicated. Extremely, and it's going to get more complicated with more options for drugs, not necessarily easier for providers, although they're going to have a lot more options. It's expensive, and it's going to be more expensive, and it's changing. So there's just a ton to consider, there's a lot to consider. But there are significant institutional barriers for patients who are incarcerated to receive treatment. And one of the biggest is duration of stay and continuity of care. Most prison systems will not be able to provide. Will not treat someone for hepatitis C unless they can stay throughout the duration of that treatment, which is right now anywhere between 24 and 48 weeks, plus the time for workup, right? There are a couple of different models out there for connecting people to care upon release. New York State has the New York State Continuity Program, which has a sort of a pool of resources for providing people referrals to care upon release so that treatment can be initiated regardless of the proximity to their release date. So there are possible models out there, but that's also going to be changing as well with new treatments that are only going to be 12 weeks in duration rather than 24 to 48. So this is complicated, but I think the bottom line here is that things are highly variable, and I think there's a need to address that across the country. All right, so I like to get back to the basics sometimes, and so when we're talking about screening and treatment, I always like to just check in with why. Why should we do this, you know? So first off, you save an individual life. By curing someone of what could potentially cause liver cancer or cirrhosis of the liver or serious liver disease, you're saving somebody's life. However, there are lots of other reasons why screening, treating, and testing in prisons is important. First off, I think that you improve the health of your institution. You're improving the health of both the inmate, but you're also reducing the potential for staff to be infected by an inmate. You're improving public health. And I think that's a big thing here. We are reducing societal costs and improving public health by addressing the hepatitis C epidemic while we're in incarcerated settings. We have a huge concentration of the disease in these settings, but we know that 9 out of 10 of these folks are going to get released. So folks who are getting released and are cured are already taken care of. Folks that are getting released who are not cured have the potential to transmit that virus to others, and also a lot of people who are incarcerated, if they get released, they no longer have health care, and so they might not ever get treated, and so the likelihood that they will develop cirrhosis or liver cancer or other end-stage type liver disease is potentially higher as well. So we also theoretically reduce the long-term cost to your institution. We have high levels of recidivism. If you release somebody without treating them now and they come back and they're sicker and they need a liver transplants and end-stage liver disease are very expensive. I don't think I need to let you guys know that. I think you know that. So we see that Treatment, there was an article a few years ago that showed that treating in corrections is cost effective. That might be changing, and there are people who are, there are people, with the drugs, the newer drugs are probably going to be fairly expensive, but treatment has been shown to be cost effective in the past. So that should be something interesting to watch as well. But by getting people engaged and involved in care now, you're reducing the likelihood that they come back to your institutions sicker. All right, so that's something to consider as well. All right, so what's being done on the education side? And that's what we're here to talk about mostly. I'm a health educator. I talk about hepatitis all the time. I like to teach people about hepatitis, and that's what my focus is in my agency. Some of the things to consider as far as what's going on right now as far as educating offenders or inmates about hepatitis is that a lot of times hepatitis C education is piggybacking off of HIV education. And I think that that's not necessarily a bad thing. That's where the dollars are for education, but also in other health education. Now, it's not a bad thing to sit down with a group of people and provide a multitude of health information. However, given how high the prevalence rates are in our prisons and jails for hepatitis C and how complicated a disease it is, the education, when it's alongside either HIV education, it either becomes confusing or the messages get lost in the shuffle. I mean, it's really difficult to provide this information when you do sit down across from a group of inmates and try to explain Hep C with them without also getting into HIV or STDs, right? I mean, look, some people will get it and then they'll fight it off. So other people will keep it for a long time. Some of those people will get sick. Some of those people will never get sick. So there's just, I mean, it's very, very difficult to explain. And so when it's lumped in with a lot of other health information, it's often lost in the shuffle. It also lacks practical resources. If you don't have access to testing or care while you're incarcerated, it doesn't necessarily have as much power to provide that education while somebody is incarcerated. If I give somebody a message that they need to be, that they should get a liver function test every 6 months or once a year, and they don't have access to that, that's not a very impactful thing that I'm doing. So we need the practical resources to supplement our education, and that includes access to risk reduction tools such as condoms and things like that. All right. We also need dedicated staff and resources. We need people who are knowledgeable, and they need the tools to be able to do the job correctly. All right. Great. All right. So why? Again, why educate people? So first off, we reduce stigma. When people are knowledgeable about a disease, we hopefully reduce stigma. And I think that this carries weight in corrections because when we reduce stigma, we increase safety. I think that there's a lot of issues in terms of stigma in the prisons and jails especially, related to hepatitis C, and if you're breaking up fights or if you're dealing with people who don't want to talk to each other or don't want to live with each other because they fear each other, when we reduce that stigma, we increase institutional safety. We also reduce risk and therefore reduce viral transmission. By educating inmates or offenders, we can potentially increase their engagement with care and allow them to ask the right questions and send the right kites to the right people so that they have access to that care. There are a lot of times where I'm teaching a class in a prison and I make them aware of a resource or a service that's provided, such as hepatitis A and B vaccinations, which is very important for people living with hepatitis C. But they didn't know they had access to that until I told them. So those folks get engaged in care all of a sudden, and also they have a base layer of information where they're now able to ask good questions and understand a little bit about what's going on with their health, all right? Which makes time spent in medical appointments more efficient and more effective. If you, as a nurse or a doctor, have to explain from zero what's going on with this individual, that takes up your 20 or 30-minute appointment, right? If that offender or that inmate comes in with a level of knowledge beyond nothing, then the conversations that you have will be more effective in a sense that you can provide better information to those folks because they're already going to have the foundation and the basics covered, all right? Or at least it makes it easier to break through some of those barriers and misinformation, all right? It helps people prepare for treatment while incarcerated or prepare for getting linked to care on release. And education potentially increases adherence to treatment if people do decide to go on treatment and have the ability to do so. All right? All right, so just making sure I'm on the right slide. So I'm going to talk about two different models that the Hepatitis Education Project provides, two different models for providing offender education. We have two programs that we have run in the prisons in Washington State. We've had a long-standing program providing education directly to offenders in the Washington State prisons. For about 10 plus years, we've had a contract from the state to do so. It is hepatitis specific. It is a Hepatitis 101 class. It is 2 hours long. We discuss the liver, we discuss transmission and prevention. We cover hepatitis A and B a bit. We focus on hepatitis C, but we cover all three. And we cover important things like self-care, especially if folks can't get treated. We provide treatment information, and we talk a little bit about navigating prison health services. Navigating prison health services can be very confusing. And it can be, like I said, people can be unaware of potential services, and we want to make them more aware of those. We want to make it easier for them to ask the right questions. And even if they aren't going to be able to get treated while they're incarcerated, we want them to at least know how to ask and figure out why. And also be able to learn more about themselves and their health while they are incarcerated, and be doing the right things so that maybe they can get treated when they do get released. So we talk about how to navigate prison health services, what an infection prevention nurse does, how to send a kite to medical and ask for hepatitis vaccines or hepatitis services, what tests what services are available to them, such as liver function tests, and what kinds of things are qualifications to get treated while you're incarcerated. So what we do is we teach 64 classes per fiscal year at 12 state institutions. We teach 2 classes per year at each facility. At our receiving facilities, we teach more. We teach once per month at the men's receiving facility and once per month, or once every other month at the women's receiving facility. It's a voluntary class. Inmates sign up for it, or sometimes they do an all-call and they just sort of let people come down who want to come down. It depends on the facility in terms of how we specifically run that class that day. So, but we have had a long-standing relationship, and we reach over 1,100 individuals per year. Oh, we also do 4 classes per month at King County Correctional Facility, which is Seattle's jail. And I'm not going to get into sort of how we run that right now, but I'm happy to talk to somebody afterwards. It's a bit more complicated because it's a much more chaotic environment than the prisons are. All right, so we do reach over 1,100 people a year, and that's, I think, a lot. However, it's not enough. So our education, our direct education, we are contracted educators. That's the Hepatitis Education Project. We think that by providing a contracted service that we help reduce costs for DOC and also increase quality. We are dedicated hepatitis advocates. Our agency is, I think, one of the cutting-edge hepatitis agencies. We're focused solely on hepatitis. So the quality of information and the ability to keep that information up to date that you get from an agency like ours is very, very good and very, very high. And I think that to have if you have somebody who's working as a nurse or a doctor, they may be very knowledgeable, except they have other jobs as well. And so keeping up to date on the latest hepatitis information is more difficult. So we focus solely on that, and that increases the quality of the material that we deliver. We also have a strong collaboration with particular people working in DOC, and I work primarily with our infections prevention nurses. They used to be called infections control nurses, but I think they recently changed the nomenclature there. But we coordinate, and we work with them to coordinate between medical, program staff, custody staff, and us as a contractor as necessary. It's actually not terribly difficult. We reserve a space. We post flyers in units and in the medical facilities, medical waiting rooms, and we allow that informs the inmates when and where the class will be. Sign-ups can range depending on the facility and what the nurses prefer. And what the inmates prefer, but we've shown that we allow inmates to sign up by Kite. I'm not sure if they use Kite in every facility, but Kite's a message and note, yep. All right, so Kiosk, which is our computer system where offenders have access to sometimes email and basic services there. We also use a sign-up sheet, although we found that people are more likely to sign up via Kite than they are via sign-up sheet because they're worried about issues related to stigma and they don't want to disclose their Hep C status on a sign-up sheet. Although we do use them sometimes in complement with each other, and that tends to increase the class attendance. Things to consider, it's really, like I said, it's not terribly difficult what we're doing. This is not rocket science. I mean, we consider where we're going to have the class, we consider how we're going to recruit offenders, the material that we're going to deliver, and what staff we're going to use to do that. In some facilities, I work solely with the infections prevention nurse, who then communicates, reserves space, and does all the recruitment. Sometimes we loop in a program coordinator of some kind or other staff, but it's not usually terribly difficult. We also consider workload because, to be honest, our infections prevention nurses get a significant spike in their requests for hepatitis A and B vaccines and Hep C testing, and for consultations related to hepatitis C after we provide these classes. So if I deliver a class to 70 inmates, and all of a sudden that nurse gets 50 kites, that's a lot more work on their plate. And believe me, these people are very, very busy already, as you know. All right, taking a break. You guys like Dilbert? Okay. All right. Seems like most people are done eating, so the lunch jokes are going to get old. I'm not going to lie, there might be one more in there. All right. So the other educational program that we recently piloted was called SHIELD. SHIELD is a peer, rather than direct offender education, is a peer education model. And this is one of the CDC's DEBIs. How many people are familiar with the DEBIs? Okay, interesting. DEBIs are a number of, they're called, it stands for, I love acronyms in our industry, diffusion of effective behavioral interventions. And what they are is they are a series, and there's a lot of them, of risk reduction interventions for HIV. And SHIELD is one model. There are many, many different interventions to choose from. But this one is called Self-Help in Eliminating Life-Threatening Diseases. And it is a 6-session peer educator training for HIV risk reduction. And we altered it and updated it to be for hepatitis C risk reduction as well. There was a little bit of hepatitis C in the curriculum before we touched it, but we added a lot. But the idea of SHIELD is not that offenders are teaching classes. The idea is that they spread risk reduction information through their social networks. And this is, the reason for that is because we feel, the theory behind this is that people who are engaged in risky behaviors themselves are likely to have contact with other people who engage in risky behavior. And some of those people will make it to a Hep C class and some of them won't. So you're reaching out further and you're trying to get into areas where maybe you weren't able to spread those messages. But I'll talk about the benefits of the peer aspect. But the idea behind SHIELD is that we teach risk reduction techniques alongside peer communication skills so that inmates can talk to their friends and loved ones about risk reduction information in an effective way. So the idea is that they spread that information throughout their social networks. It's not necessarily a formal class, although that's something that I'm very, very interested in as well, as using peers to teach our direct education. However, that's a little bit about SHIELD. It's drug and sex-related risk reduction techniques. It is a harm reduction model. I'll show you guys one of the tools here in a minute. But it requires, we teach peer communication and leadership skills alongside those risk reduction techniques. It is a small group, so it's 8 to 12 people at a time. And like I said, it's 6 sessions long. There are other peer education models out there. Some of them are longer, some of them are 4 to 6 sessions. It depends sort of how deep you want to get into the information and what you want to do, which I'll talk about in a second as well. SHIELD was originally aimed at current and former drug users, HIV positive or negative. Before I talk about how we implemented SHIELD, I just want to talk about why peer education. Well, when I come into a prison, I'm not a prisoner. There's a level of credibility and trust that peers have that outside educators don't always have. How many people, if their high school teacher told them something was cool, thought it was cool? How many people, if their friend in high school told them something was cool, right? That's the one. So that's the idea behind peer education. And obviously, trust between inmates and staff in prisons, there's a gap there. So the other piece is sort of being able to reach the hard to reach. Like I said, these guys are folks who see people engaging in risky behavior every day, and not all those folks are going to be able to sign up or have access to classes to take to learn about hepatitis risk or HIV risk. So we're reaching out hopefully into social circles who might not otherwise have contact with this kind of information. It also is inexpensive and it keeps your staff free to do other things, all right? we increase knowledge and decrease risk behavior. That citation is from the original SHIELD study. They found that the peer educators increase their own knowledge and decrease their own risk behavior in addition. So there are other successful examples of peer education programs having been implemented in prisons around the country. SHIELD was done here in Washington, or there in Washington. Wall Talk is a program that's been successful in Texas. PHEP is run by a agency called Centerforce in California, and they've been doing it longer than I think anybody. They have both paid and unpaid peer educators. Their unpaid peer educators more like SHIELD, where they disseminate sort of information in their social circles, but their paid peer educators are actually highly trained and deliver what is essentially the class that I teach in the Washington prisons to offenders in the prisons there. They're a great resource for hepatitis information. They're a network partner of ours, and they have a lot of tools for teaching about hepatitis in prisons and jails. So please check out Centerforce if you get an opportunity. Also, in New Mexico, there was a peer education program that was run by Project Echo down there. I have contact information for all of the people who have run these programs before. So if you'd like to communicate with any of them and ask them about best practices, I'm happy to do that for you. And actually something that we're trying to do more of is sort of connecting people through this network, and I'm going to talk about that at the end. So how did we implement SHIELD? Excuse me. It's an awkward moment of silence. Who was that guy who had the weird water moment, like right after the debate? I don't remember. Anyway, hopefully I did better. All right. So as far as we know, this is the first time that SHIELD was ever implemented in a prison. It was well received by both offenders and administration. We customized the SHIELD curriculum to include additional hepatitis C risk reduction information and also to be correction specific. There is a lot of role play involved in SHIELD, and we wanted to make those situations applicable to prisons. So we have this curriculum. I'm happy to talk to people about it and share it with people if necessary. We worked sort of like we worked with the regular direct education classes, where I partner with an infection prevention nurse. Now, SHIELD requires 2 facilitators. It's best with 2 facilitators. It can be done with 1, but it's best with 2 facilitators. So I, as an outsider, came in and co-facilitated along with somebody who worked inside the prison, and that was the infections prevention nurse at each facility. But whoever your best facilitator is going to be somebody, because it's a fun program to facilitate. But we piloted it at 4 facilities. We did 1 cycle each, so we trained between 8 and 12 individuals at each cycle. We ended up training 28 inmates as peer educators. Because this is information that gets spread among social circles, specific outcomes for SHIELD are actually very difficult to track. And so that was one of our big challenges, and being able to sort of talk about what were the tangible outcomes is difficult. However, the funding that was provided to do this pilot was looking actually more at implementation strategies and whether or not this was going to be effective in a prison environment, and we definitely demonstrated that this is feasible in a correctional setting. I would love to take it to the next level and really do some serious outcome monitoring, and we're going to be working to do that. We're having issues securing funding. One of our somebody who was a champion for us left right before the budget switch. So, and DOC had a big budget cut for Washington, just like everywhere else. So we're working to secure funding, but I'm confident that at some point we will be able to do that. We're trying to keep the momentum that we created, but if anybody has any ideas, come talk to me. But I'm very excited about what we did, and I would love to replicate it. I would love to take it into our receiving facilities as well, so that people can, as they move from institution to institution, be a voice for that. And then the other piece is that I would love at some point to be able to use our peer educators as supplements to our direct offender education as well, which is shown to be very effective in California. This is one of the tools that we use. So this is one of the tools that we created. So SHIELD uses, this is just one example, and these are available online. I'll tell you where they are. But SHIELD uses a harm reduction model, and what we talk about is risk reduction. It's focused on risk reduction, so we don't focus necessarily on treatment and self-care and those types of things the way that we do with our direct education. This is about reducing viral transmission, and we use a harm reduction model. So what this is a risk ladder, And let's see if I can get the laser to work. No. Okay, doesn't look like it's working. I don't need a laser. All right, so tattoo risk ladder. So this is for hepatitis C. This is one of the additional tools. So SHIELD came with a sex behavior risk ladder and a injection drug use risk reduction ladder. However, for hepatitis C, it's important to talk about tattoos. So we created a tattoo risk ladder, and what these tools are is at the top of the risk ladder are behaviors that are the highest risk. It's probably difficult to read this, but I'll give you an idea. At the bottom of the ladder is the behavior that is the lowest risk. So not getting a tattoo would be a low-risk behavior for getting hepatitis C from a tattoo, right? All right. We all know that. So what's the riskiest thing? The riskiest thing is at the top of the ladder, and the riskiest thing is getting a tattoo on the street or in prison with a used needle and ink. All right? That would be a very risky behavior for getting hepatitis C. So a lot of times we give those black and white messages, okay? Don't get a tattoo or get a tattoo and that's that. But we try to provide options so that when people are having real conversations in real time, they're able to meet people where they're at. And that's that harm reduction piece. So along the risk ladder, you have at the top, and you always start with the riskiest behavior and end on the least risky behavior so that that's what's freshest in their mind. But you start with not sharing needles and ink, right? Then you have getting a tattoo on the street with a clean needle but reusing ink, which is one way to get infected with hepatitis C. We also have using a sterile needle and ink every time you get a tattoo, but not necessarily getting one in a shop, right? Then getting a tattoo in a licensed professional tattoo shop, and then not getting a tattoo. And the idea behind presenting something like this is to give people realistic options so that when they find themselves faced with a particular choice, they don't necessarily look at it as a black and white, I can do this or I cannot do this. They have options for decreasing their risk without necessarily eliminating it entirely. And obviously we always emphasize that the safest thing, like with injection drugs, is not to inject drugs. However, many people do inject drugs. And if you're going to inject drugs, you can't get hepatitis C if you never share a needle, a syringe, a cotton, a cooker, or rinse water. All right, so we don't want to encourage use, and that's that harm reduction piece. We're not trying to encourage drug use, and we're not trying to encourage risky behavior. We're simply trying to provide people with realistic options. How much time I have? Good, all right. So some things to consider when you're implementing an educational program like SHIELD are how you're going to create eligible participants, and I think that that's something that's difficult. Peer education requires a high level of cognitive ability, and so you've got to consider, sort of who you want to be involved. The harm reduction model can be a difficult sell to administration sometimes, so that's something to consider as well. How you're going to staff the program, and also this is 6 sessions long rather than a one-off, so custody and staffing related to that is an issue. Ability to follow up, and what I mean by that is tracking your outcomes depending on how you're using your peer educators, but that's also something to consider. Which peer education training you use depends largely on what you want from your peer educators. If you want them to talk within their social circles, then SHIELD is a great model. If you want them to be delivering classes at unit orientations or something like that, then maybe you want to consider something else. So I'm happy to connect people to different models as needed. And the feasibility of all program aspects, so thinking about group size, thinking about participant work and program obligations, and then also thinking about what are the lessons and demos that whatever model you're using require. SHIELD actually uses a demonstration of safer injection. And we actually, in 3 out of 4 facilities, were allowed to do that demonstration, and also a condom demonstration as well. So whether or not your facility allows those types of things is something to consider, because you could still do this, however, it's slightly less effective. So you have to consider what the program requires and whether or not it's usable in your facility. So just to compare sort of the 2 models, we've got our direct education and our peer education. The direct education provides for a deeper level of information. We are able to talk about treatment, self-care. It's 2 hours long. We have expert educators who are very knowledgeable, and it's less time intense because it's a one-off. However, we have those issues around trust of outsiders, and also related to trust, and we potentially don't reach a lot of people. All right, we're reaching people who sign up for the class, who are interested in the class, and so we're not reaching people who need that information, who might not either want to disclose their Hep C status, or people who there's a lot of people who we aren't reaching that way as well. So with peer education, I don't mean credible like experts, I mean credible like authentic and trustworthy. And so the peer educator is more credible to his peers than an outside facilitator. It also keeps information simple, and you reach potentially, theoretically, you reach a greater, your reach is greater. However, you get less in depth with the information. It's more time intense because it's 6 sessions long or longer, depending on what model you choose. And it's more difficult to measure the outcomes because how do you really measure people's choices? You can measure intent to change behavior a lot more easily. All right, so take a quick break. That's a lot of information, right? So just take a deep breath. Okay. All right, so the last thing I want to do is talk a little bit about, so those are our 2 models. I am very happy to talk with everybody and anybody about how we do that. And one of the things that we are doing at the Hepatitis Education Project is we are trying to connect people who are working in prisons and jails on issues related to hepatitis C to each other and to resources and information. And we've created a network called the National Hepatitis Corrections Network. It's a collaborative network of anybody working in healthcare related to hepatitis C in prisons. So that's prison administrators, clinicians, healthcare providers, community-based organizations, or people like me who are health educators. And what we're really trying to do is increase and expand access to information and resources for hepatitis C in corrections. It's a fine niche, but it's a very important niche. And we're doing that through sort of 2 venues. We're connecting members to members. So a great example was the other day, somebody who I never met saw this website, called me and said, I've been looking for videos on hepatitis that I can show to prisoners. Do you know anything? And I said, absolutely. Here's 8 of them that Centerforce, one of our network partners, produced. So there's that simple connection, but then there's also the ability to collaborate and create new projects. And we're working to share best practices and list information. We want to list program models and professional development opportunities and create new resources for both inmates and for professionals. Our website is going to be the clearinghouse for that information. So we're hoping, and it's right now we're basically unfunded, and so this is a new project. It's being built. Our website is rough around the edges, but it's getting better. But if you have any information, resources that you'd like to make available to others working in this field, we would love to host it on that site. And likewise, you are welcome to visit that site and download anything you see there too. And that site is constantly getting updated and is going to be getting better and better. We're also producing a quarterly e-newsletter, and we have quarterly conference calls with our core network members. If you'd like to become a member or if you'd like to sign up for the newsletter, you can visit the website. I've got cards on a lot of these tables, so I'm being a little shameless on this. But this is a really exciting new project. I can't emphasize enough the interest in this and the interest that people have in trying to collaborate, because when we all work together, it works better. And I think also when we share information with each other, it works better. So there are a lot of reasons why we hope to be able to connect people to information and create new projects. And I'll give you an example. We've created a new resource that we actually just posted to the site. This is a brief guide to hepatitis C for people in prison or jail. And in some of my conversations that I was having with my network partners originally when we were trying to discuss some concepts for this, we talked about the fact that there's a lot of hepatitis C handouts, right? But very few or almost none of them speak directly to people in prison. And there's a lot of Hep C in prison. And so we wanted to create something that really was for the prisoner, that was simple language, but also we don't have any money. So we said, how do we do this cheaply? And we created a very, very simple document that you can download at home. And all of you could go to this website right now and download this resource. It's a little booklet. It can be tricky to print. If you have a hard time printing it, you can call me. Or you can print it as a 2-page back-to-back type handout as well. But it's simple messages, it's easy to use, and you can download it directly from your office and print it yourself. You don't have to order it, and I don't have to mass produce it. We're hoping to find funding to create some graphic design around this. I'm not a graphic designer, so this was created in Publisher, and I think the messages are very good. It is geared a little bit more towards people who have a little bit of knowledge, but we hope that it's useful. And if people find it useful, or if people have any feedback about this, we would also love to hear it. Another thing that we're working to do, and let me just see, I think I've got a few minutes left. All right, so another thing we're trying to do is share information about screening and treatment practices across the country. And we are not in the business of getting anybody in legal trouble, but we are in the business of sharing information and trying to create sort of a warehouse of best practices. So we're working to compile information related to screening and treatment practices in state systems and private systems around the country. And eventually we'd like to sort of create an online warehouse of that information so that somebody in one state can learn what people in another state are doing. Now, we want to be as protective as possible because we're not in the business of getting anybody sued. So we're going to be trying to do two things. One is we'll put any information that we do post to the website would be posted alongside a disclaimer explaining that this is a simple summary and it's not necessarily an official protocol for treatment or screening. And likewise, we're considering limiting access to sort of a vetted members of our network where they would have to log into a secure access point on the site. So that's just something that we're working on. Oh, there's a screenshot of the website as it looks right now. Very pretty. I'm working on it. So that's something that we're also trying to do, and we're really trying to sort of create really brief, basic lay summaries of what different systems around the country are doing. So that's something that we hope to be able to achieve. So if you'd like to talk to me about that, or if you're somebody who's sort of reserved about sharing that information, I'm happy to be as open and transparent about what we're trying to do as possible. We're trying to create resources, and we're trying to share information, and that's what we want. So, some conclusions: that correctional institutions provide an optimal setting to address the Hep C epidemic. Actually, Dr. Morjani gave a great presentation the other day in the morning on Monday and talked about this being actually an optimal setting from a physician standpoint to treat. So it's great. Effective educational interventions exist, and there are models, and our network can help. The Hepatitis Education Project can help. There's a lot of work to do, and we hope that our new network is a great forum for connecting all of you to best practices, resources, information, and technical assistance as we go forward on that. So please contact me. And I'm spent, just like this guy. I saw that. Thank you. All right, so I saw that picture, and I was like, where am I going to? I have to use that somehow. So, all right, thank you guys. I'm happy to take questions if anybody has them, or I'm happy to talk to you guys after. And I don't know if Kim, is there like a mic for questions or anything like that? No? How do you choose somebody asked me how we choose the peer educators. So with the SHIELD curriculum, there is a screening form that sort of asks a list of questions about why they're interested and then we do have a brief interview with them. And so I worked with the infections prevention nurses to sort of pre-screen folks. We did focus on people who had a history of drug use. Anybody else have a question, or I'm happy to talk to people after?